Let's go ahead. It's 8 o'clock, and the scheduled hour for our lecture. We had a spectacular talk yesterday by Dr. Anil. This year's keynote lecturer for the H. Bernard Zimmerman Research Symposium that we have each year. This is the highlight of the academic year for us, where residents present their research, which will follow Dr. O'Neill's lecture. We went over some of Dr. O'Neill's and mine personal background. Everyone, I think by now, knows that Dr. O'Neill trained me in pediatric surgery. Also, Dr. Shorter and Dr. Ross were together at Children's Hospital of Philadelphia, where he was surgeon-in-chief and program director in the training program pediatric surgery. He has an extensive background in pediatric surgery. He's an honored pediatric surgeon, internationally known. He was president of the American Pediatric Surgical Association, which is the preeminent professional organization in pediatric surgery. He also won the LAD Medal, which is the highest honor of the surgical section of the American Academy of Pediatrics. He went from Children's Hospital of Philadelphia to be chair at the department or the surgical section of surgical sciences at Vanderbilt University, which is the umbrella organization of all surgical specialties at Vanderbilt, where he led a very robust group of surgeons and led that admirably. He's held major leadership positions in nearly every major professional organization in surgery, including vice presidencies of the American College of Surgeons and the American Surgical Association. He was president of the Southern Surgical Association. We're very honored to have Dr. O'Neill here. It's a personal treat for me to host him. And Dr. O'Neill, we're looking forward to your lecture.
As you can tell, Dr. Nakayama is a very good friend of mine. And all I can say is I hope the good Lord will forgive you for some of the fibs you've told. Or in farming terms, what they say is a little bit of it helps the grass grow and make it green, and a lot of it burns the grass. So I don't know which happened this morning. I thought you might get a kick out of this. I didn't show this yesterday because he showed a picture yesterday. Is it on there? Yes, it is. Both Dr. Nakayama and I had hair at that point in life. And this happens to be his graduation picture when he finished his pediatric surgical fellowship. And he showed a picture yesterday that had 3 people in it, including Dr. Shorter here and Dr. Ross. And so they were the unholy 3 of the group at the time. But we had a good time, and like a lot of things, those are close relationships that have lasted a lifetime. We know each other's families and children and so forth and so on, and that's obviously a very nice thing as you go through the years. And so it is, I can tell you, very heartfelt on my part to be here. Because I know that the only real reason I'm here is because Dr. Nakayama has a little warm spot someplace up here, which is nice for me, and I share that. Well, you heard some of my travels, and that's sort of my current interest and things that we're doing and some of the research that's associated with it. And I have to tell you, probably right now is one of the happiest times in my life because I'm doing everything that I like to do. I don't have to any longer do any of the things that poor Dr. Nakayama has to do. I don't have to listen to any of the whining. I don't have to take complaints. I can look up to the office that I used to sit in and say, that's not my job. It's not my worry. All I have to worry about is whether I can keep my NIH grant and whether I can do the things that I want to do in global health. And I hope that all of you will have the same sorts of careers where you can be gratified with what you're doing in medicine, because if you can look back on your career and see that you have contributed at least something to people and to institutions, which means that you would contribute to communities where you live, those things will be the things that will make you the happiest alongside your families. So let's talk a little bit. I want to hear more about what you all are doing in terms of research, and that's really the purpose of this morning. So I'm going to try to cut my remarks down a bit for the purpose of hearing what you have to say. So let me see if I can pull this up. It's clicking. There it goes. Well, why did I get interested in this subject? Well, because I'm a pediatric surgeon, and like a lot of things in advanced medicine, we worked with other specialists, and in particular perinatologists. We have a fetal evaluation center at Vanderbilt, like it exists in many places. Every Thursday at noon, we have an hour conference, and we review the cases of the week, which run between 30 and 40 cases a week. I have to scroll down in order to see all of them. Many of them are things that don't concern pediatric surgeons, but it's rare to have a Thursday when we don't review a number of cardiac anomalies, a lot of genitourinary anomalies. Almost always there are 2 gastroschisis patients every week. And so we are able to plan, we're able to counsel families, and particular mothers. There are 2 of us that do that. I'm not the main person who does it. A fellow by the name of John Peach runs that program. We are part of a 3-institution consortium studying myelomeningocele. It's called the MOMS trial, which is a randomized trial of intrauterine surgery for correction of myelomeningocele. The first case ever done was at Vanderbilt. The largest number of cases done has been at Vanderbilt. Many of you may have seen the New England Journal of Medicine article reviewing the results of that randomized study that showed that it was a worthwhile endeavor, that there were less cases that needed ventriculoperitoneal shunting of those children who had had prenatal surgery. There are a lot of lessons that have been learned, for example, how to quiet the uterus so that you can operate on the fetus, and how to manipulate cases at that time. Our effort has been solely with the evaluation of myelomeningocele. Our efforts at Vanderbilt in pediatric surgery and otherwise in the multiple specialties that are involved has strictly been on a research basis. It's been funded research from the beginning. I head the ethics committee of that study, and for me it's been very fascinating. My experience with prenatal imaging started when I was in Philadelphia, when these fellows were around, and I don't know whether they remember, but one of our colleagues, Jack Templeton, and myself, and a couple of others, put together experience demonstrating how prenatal evaluation can demonstrate choledochal cysts. And that led to discussions about when should you operate on a choledochal cyst that you know is there, and so forth. Now, you know, everybody, whether they're a student or a resident these days, will come out and say, well, what's the take-home message? Okay. Well, there are several when you look at this, and the first take-home message is that from my vantage point, and I would think from your vantage point, that the take-home message is that it's not just to image. It's to get some information about developmental biology and the physiology of the events that are occurring. And that information, some of which will be new, if you stick with it appropriately, that information is useful in terms of treatment. It certainly is useful in terms of prognosis. It certainly is useful in terms of counseling parents. And many of these, of course, are young mothers, not necessarily very sophisticated in medicine, so counseling takes a little longer than it might otherwise. Well, what do we know about the experience from fetal imaging? It's very common these days. It's been around for well over 20 years, but it's better than, like everything else, than it used to be. So why do you do it? Well, these are current figures. About 2 to 3% of the births are abnormal, and that's probably an irreducible figure at this stage of human evolution. And when can you do it? Well, it really is not very good information below 14 weeks of gestation. Or if some people do this by means of trimesters. But by the second trimester, these are just general rules for you now, the abdominal organs have attained their adult positions. So you have some feeling for what should be seen, and when you see something that isn't what you think should be seen, because we have the data on that, then you know you have a problem, and then you go into it a little bit further. Now, we basically have these three tools. We have more tools than this, but those are the primary tools that are used. Occasionally, CT scanning is used for very specialized things. Now, at our institution right now, we depend primarily on ultrasound. We no longer do as many MRIs as we once did, simply because we now have good enough ultrasound and 3D ultrasound that it allows us to do most of what we need to do with that technique alone. And the Doppler is used for blood flow studies. Now, when is it accurate? When is it dependable? Well, obviously, you're taking a high-risk pregnancy and following that, and you image more often later when you get to the late second or early third trimester. But early on, you're able to evaluate fetal size and configuration. You're able to tell something about the amniotic cavity, and there's physiologic information in that, by the way, opportunity for research. For example, in those cases where amniocentesis is going to be performed because of a family history, the imaging of the amniotic cavity can be extraordinarily helpful, and also helpful in terms of doing accurate amniocentesis. And then you can get some idea about cardiac structure. But it's not until later, the second trimester, that you begin to see these things that have pathognomonic images. And then finally in the third trimester, you can obviously very accurately describe things. For example, we have a large experience with conjoined twins, which has been accumulated over a period of time. And many of those have cardiac abnormalities. And so we are able to determine pretty much with our team what things are correctable and what things are not. And so in some instances, we're able to say that's a form of conjoined twinning that is not separable, and that those babies obviously will die. So there are limits to what we can do, but it helps us get this information early in terms of counseling. Oops. Wait, let me get this. Okay, there we go. I punched two buttons. So when do you do it? Well, first of all, high-risk pregnancies, family history, previous pregnancies that were in trouble, and so forth. Every pregnancy gets screened pretty much today with alpha-fetoprotein. That's particularly important for myelomeningocele. And even with folic acid supplementation, we still obviously see a large number of babies like this. And then maternal diabetes, which is known to be associated with a number of things. Increased or decreased amniotic fluid, and then various syndromes in a family. And if you have certain populations, you will have higher incidences of anomalies because of sort of peripheral consanguinity. And so can't get into all of that today, but there are a number of things, and certainly this shows up in Africa. We are able to do some prenatal screening over there with ultrasound, but not a lot. So what do you look for? You look for fetal size and organization. You look at the amniotic cavity to see whether there's too much, the right amount, or too little amniotic fluid. You look for neural tube defects, the thorax and the heart. And as you go, second and third trimester, these studies are very accurate. And then you can supplement that with things like amniocentesis, other types of serum studies, and all the rest. Now, at 17 weeks, this is the sort of thing that you can see. You can see cleft lip and palate at this stage of the game. You can put that into a format that's three-dimensional. This is the same 17-week. You can see that the skull is still open at this point. And by turning the image, which is possible to manipulate with appropriate software, you're able to look at this very, very accurately. And you may see things like this where the fetus is disorganized, where you've got bowel out here, you've got liver up here, you've got this and this, and it's obviously a disorganized situation. You can look at the fetal spine and the conus of the spinal cord. It's not until late that you're able to look at the fetus and tell whether there's a tethered cord or not, with nerve roots that go more at right angles than as they should in a normal leash. So there's a lot of anatomy that you can pick up with studies of this nature. And you can do 3D imaging like this, which allows you to tell bony structure. And you'll see a lot of this relates to myelomeningocele because that's been the primary interest at our institution and in our group. And I must say it's been fascinating to see this. Our effort has been to operate toward the latter part of the second trimester, beginning of the third, so that you don't have as many early deliveries and premature infants, because then you may have more problems than you're trying to solve. And that has worked out very well. If you look at the three institutions that have been studying the MOMS trial, which is now in the follow-up stage of the grant, no longer being randomized because it's been proven to be appropriate for routine care of those families that wish to have it. At any rate, you can see that that's where we put our emphasis, and this is applicable to other types of anomalies. You can see early signs of the brain with fetal brain cysts. I've labeled these for you so that you would have some idea of what this all looks like. Because I know when I started out, I didn't have a clue what these shadows meant. And I presume you do the same. But if you work at this, you can see how, well, somehow, or you can look at the heart. Now, you really can't see really accurate pictures of the heart like you would want and in a dynamic fashion until the latter stages of pregnancy, third trimester. You can see something early, particularly if it's disorganized, but if you want to see precise anatomic detail, you have to be well into the third trimester. But here you can see valves and so forth and so on. And there's only one static image because you get many, many with ultrasound. So at one point in time, we were getting MRIs on virtually all of them, and no longer do we do that. And here you can see the arrows are there for you. Left ventricular mass. You can see what the aortic arch looks like, and this is at 20 weeks. And you obviously can see abnormalities of that. You can see coarctation of the aorta. You can see what is a diminutive outflow tract with hypoplastic left heart syndrome. And I think that this is one of the major advances in terms of planning for delivery, particularly for things that are predictably cyanotic types of heart disease, or babies that have arrhythmias because of congenital heart blocks and things of that nature. And you can see things like congenital AV malformations, which involve the vessels of the aortic arch, like in this infant, where you can see there's an AV malformation which is within the chest, and something like this in utero causes congestive heart failure in utero. When that happens in utero, then babies like this will develop myocardial fibroelastosis, and many of those will not survive. And so they may have earlier intervention. And then there are disorders of the trachea. I'm just sort of going around giving you examples of this and how they may be useful to you, or sort of my mentality, I like to try to learn something from it. When did the abnormality occur? For example, we've been able to describe that choledochal cyst is a second trimester abnormality. So you say to yourself, is there anything you could do before the second trimester or early in the first trimester if you could see it? Anything you could do to alleviate that situation. So anyhow, those are some of the things that we look for and which are demonstrable. And here you see an example on MR of tracheal stenosis here. And this is where MR can be particularly helpful. This is possible to see agenesis of the lung, something of this nature. One can look at the lung itself, and in certain abnormalities like sequestrations of the lung, or and I'll show you something called a CPAM, or congenital abnormality of the lung of a cystic nature, or it can be adenomatoid. You can look at the lung and you can look at the kidney, as I'll show you later. Now, here you can get a picture. This is illustrative of the amniotic sac. You can see there's too much amniotic fluid under these circumstances. And you go into it further. This is a CPAM, or congenital pulmonary adenomatoid malformation, which you see here in the lung. And these pictures are pretty darn accurate, as you can see, in the thorax. You can see overexpansion of the area where there are cysts. This is what it looks like. And we don't tend to take these out early. When we see these in utero, we now use steroids in higher doses that then would be used to protect the lungs otherwise, and only when they're very large and are unresponsive. So we don't do as many as we used to do. But there's an advantage of prenatal imaging in that a trial of steroids can be followed under these circumstances. Who ever thought this would be part of pediatric surgery? But it is. And here you can see a sequestration, which is evident in here. Another one that you see here. They light up. You can see an abnormal vessel going into it, a systemic vessel. That is evident, as you see, postnatally. See, a lot of this is not done primarily for intrauterine surgery. It's done to demonstrate something that allows you to take care of a baby early so they don't languish. And here you can see another picture of an abnormal vasculature. And this is what that looks like. A large subdiaphragmatic vessel traversing and going into this intralobar sequestration, extra tissue. You can get a good look at the fetal diaphragm and tell whether it's intact or not. This fetus is on its side, diaphragm here, liver underneath. And you can get a good picture of a diaphragmatic hernia. Almost looks like a regular x-ray, as you see here. Now, there have been trials of intrauterine surgery for diaphragmatic hernia. There still are some trials of tracheal occlusion in order to kind of blow up the lungs. It remains to be seen whether those lungs have more lung units or whether they're just blown up. And that's data to be determined. But the correction of diaphragmatic hernias has been held off for a while. And here you see another one on an MRI. And I think you can see here that the MRI didn't add that much information to the ultrasound, and that's the route we've followed. And this is what it looks like following birth. And then gastroschisis. Now this is another story. Here you can see the fetus, the abdominal wall, and here's the intestinal tract outside. Now this is a matter of transition of thinking. At one point in time, as babies like this were followed, when we saw a progression to thickening of the bowel wall, we thought that maybe that meant that that was a time when you were going to see a great deal of membrane around the bowel, and that there had been some ischemic damage. And so there was a move to intervene early following birth with cesarean section to get those babies out. Well, that really turned out not to be correct. It was reasonable reasoning, but incorrect. And so what we worry about more now is when these loops thin out, because we've seen perforations under those circumstances associated with bowel atresia in association with gastroschisis. That's antenatal exposure of the viscera. So now we have turned 360 degrees. Okay? All right. Here you can see another picture of that. Here's the abdominal wall, and here's everything that's outside. That's what it can look like at birth. I'm moving along because I want to hear you guys talk. And then, again, same thing only with an omphalocele. So that's a covered anomaly. And you can be ready for that. You can also see the location of it, see whether it's associated with cardiac disease, diaphragmatic and pericardial defects, things of that nature. So you can be ready, and the baby can be born in the right place. If you make that into a 3D from ultrasound, you can see that there at late second trimester. Another view of the same thing, but with MR, all outside. And a little better view on MR. Certainly you can see the exteriorized area and have some idea what you're going to do with that. But again, we pretty well are not doing this anymore. We're doing primary ultrasound. And you can see some other things, whereas there's an omphalocele, but also below there's another exteriorized area, which is exstrophy of the bladder. This is what the omphalocele looks like. This is what the exstrophy associated with omphalocele looks like. This happens to be exstrophy of the cloaca, which is a challenging reconstructive thing, but it's nice to know that ahead of time. Most of these babies are small. You can tell what the stomach looks like. Here you see that here. It's a little larger than it should be, so you're suspicious of an intestinal obstruction just beyond it. That can be followed. And here you can see what duodenal atresia looks like on an MR. The MR is nice because it lights it up for you, but frankly, the ultrasound is perfectly adequate. And here you can see some loops that go beyond the obstructed duodenum, and here's what it looks like following birth, so that there is not complete obstruction of the duodenum. There's a little opening of stenosis that allows it to go through. You can look at the mesenteric, superior mesenteric artery. This is a hallmark of malrotation, depending upon the angle at which that takes off. However, I'm not sure it's as accurate as looking at the duodenum itself. And here you got some idea of malrotation with obstruction on ultrasound. And it's obvious that the big bowel is the one that's obstructed. The double bubble, which is only partial because there is something beyond. And on MR, you can see the duodenal obstruction here, and there's meconium in the colon. And this is reminiscent of older studies that were done. If you have complete obstruction of the duodenum, how can you have bile-stained meconium in the colon? How did it get there? I'll leave that for you to look up, because there are studies that that tell you. But you see, this is where you can look at images and get some feel for answering the questions about what's going on. And sometimes you get the answer about why. And here's a congenital diaphragmatic hernia, which I think you can see again here. And again, another picture of duodenal obstruction following on prenatal imaging. Proximal jejunal atresia, where there are more loops. And it's interesting, we have for years gone through regular conventional x-rays and made these determinations. Now we're able to do it during gestation. And then when you have lots of bowel, it looks like this. That means more distal atresia. And here you can see it here, again with ultrasound. And this is what it looks like when they're born. And if you have a rupture of the bowel, perforation of the bowel, you begin to get signs of Meconium Peritonitis, which you can see with speckles of calcium within it. And this is what it looks like otherwise with the centrally placed bowel. So I'm giving you some correlation between what we see following birth, which was the conventional way we encountered infants like this. In many cases, it was a surprise that there was a problem. And now we have a good idea. Choledochal cyst, abnormalities of the common bile duct of various types. I won't go into that in great detail, but here you can see that saccular form of choledochal cyst in that fetus. And in a normal situation, this is reversed. Obviously, the lungs are down here and the liver is here, but you can get a picture of the liver and might be wrong with the liver, particularly in familial liver disease patients where there's a family history. One can look at a Doppler and tell about the structure of the liver, particularly the vascular structure, and you can see instead of a nice single ductus venosus, you can see that this is one that has numerous branching, almost like a sponge-like network. Very early persistence of what the ductus venosus within the liver looks like. This happens to be in conjoined twins, and it's very important because those babies have joint livers, and so it's helpful to us in planning for that. I have a whole series on conjoined twinning that I'm not showing today. You can see abnormalities of the liver. This is where we're first suspicious of left hepatic hemangioma. There's more vasculature than there should be on comparing to the right lobe of the liver. You can look at it this way. You can see that it's basically a big AV malformation. It looked like this on CT or angiography. If it had bled like this one did, it had to be operated on as opposed to other measures. You can see a fetal hydrocele. And of course, everybody likes to know what's the sex of the baby going to be. And sometimes you can pick up abnormalities. Some people are traditional and don't want to know, right? You can see a thyroid mass. And this is particularly important in mothers that have had thyroid disorders or thyroid medication. And cystic hygroma, neck abnormalities. This is very important for the time of delivery because of airway problems, what it looks like postnatally. Sacrococcygeal teratoma. So we're going right on through the body. And then you can see it here on MR with all of the findings at that level. And this is what it looks like following birth. You can look at the kidney. This is normal fetal kidney, which is lobulated. This is normal distribution of vasculature, recapitulating normal anatomy. It's obvious if it doesn't look like this, there's something wrong. And you can look at renal volume, because many babies that have obstructive uropathy in utero will have renal dysgenesis, loss of cortex. This can be told ahead of time. Sometimes it's not reparable, as in Potter syndrome, where here you see there's essentially no amniotic fluid, diminutive dysgenetic, no good kidneys, and that's why there's no amniotic fluid. You're able to see hydronephrosis with cystic formation of the major calyces. And there's some discussion about whether you should intervene early or not. My own feeling is it's a done deal by the time you get to the second trimester. Or you can see a duplex system. Now, it's interesting, in the United States, as a pediatric surgeon, we don't do pediatric urology. But in Kenya, there isn't any pediatric urology, so we're it. So we've had to bone up and get to be better at that. And so you see that type of abnormality. You can see what a multicystic kidney looks like. And this can be familial, as you well know. And then you can see dysplastic kidneys that basically have no function. An ectopic ureter, ectopic duplicated ureter. And those we intervene early on. An ectopic ureterocele, full bladder. And that basically is, I tried to kind of move quickly through that so that we would have more than enough time for resident presentations. So what's the purpose of this? Well, another take-home message for you all, meaning the students and residents primarily, is that no matter what you do today, you can't consider that you are the end-all. You have to work with other people because medicine has moved technologically and knowledge-wise to a point where patients are benefited from being in a place like this where there are multiple specialists. And you avail yourself of that, and if you do, you learn a lot. So you must become conversant with the, for example, in this example, with what perinatologists do, obstetricians who focus on perinatology, because if you can't speak their language, you can't communicate, and the patient doesn't benefit. You have to both be competent to counsel. So this is an expansion of the field of pediatric surgery, conceptually and in practice, that perhaps we might not have thought about. One of the ladies here is going to do breast oncology when she finishes. But she will not be a good one unless she also avails herself of oncologic knowledge, radiotherapy, et cetera, et cetera. Now, I know she knows that, but I'm just giving that as an example for you. So I'll stop here, but what I'd like to do is to hear now comments from the residents, and that will be enjoyable to me.
We have time for questions. Are there any questions?
We see more and more now. What's the steroid approach?
Well, that was a serendipitous observation, much like propranolol for infantile hemangioma, where patients were routinely operated on, and the use of steroids in patients that are likely to deliver early has worked to mature the lungs at an earlier time. So that it had been used in low doses, and lo and behold, there were some patients that had cystic adenomatoid type malformations of the lung, and small ones would disappear. So this was a serendipitous observation, and then trials began, and now I would say that at least 3/4 of such patients are treated with steroids alone, and then they're followed after that. So I'm sure your OB perinatology people are using prenatal steroids. I'm sorry, I didn't make that clear. Prenatal steroids. And that was an observation based on lung maturity first, and then it was shown that this would make these things sort of shrivel up. But in the past, we've done percutaneous ablation of large cystic adenomatoid malformations in utero. But you know, there's a lot of spillover with RFA used for that purpose. It's okay for liver problems if it spreads a little bit, but it's not so good in a fetus if it spreads to the lungs or adjacent things. So we had to give that up. You couldn't make it accurate enough because of fetal movement and so forth. But it is a technique, and then we would operate on them. But we don't do that anymore, except in a small number.
What are your criteria now for operating?
Well, basically, it's if they're big enough to cause a physiologic problem, they take up any significant amount of thoracic space. Part of it's a judgment call. Part of it is a physiologic observation. But I'd say it's only 1/4 of the patients that we used to operate on.
Small asymptomatic.
Well, I think if they're there long enough, we end up operating on them anyhow, because there's, you know, you're going to have to follow that for years and years. And But it has gone the route of single polycystic dysgenetic kidneys, where you wait it out and they just shrivel up and go away. So we don't operate on any of those anymore. Whereas we used to, because we didn't know, but now with follow-up, we do that. It's an evolution of care.
Do you see any difference between the different types of CCAMs and responses to steroids? Has that been sorted out?
It may be, but I don't know. I haven't seen that there's any sorting of that. What you're referring to is some are very adenomatoid. They're not as cystic as some others. But I have not noticed any real difference between them. Dr. Vaughn?
The advent of the new ultrasound, 3D, higher energy, higher density, there's some concern mainly causing damage to the fetus.
We don't have any evidence that there's damage to the fetus with current techniques. I couldn't answer that. We have state-of-the-art stuff because we're a very large fetal evaluation center. The three institutions in the MOMS trial, for example, are ourselves, which is the largest center, Children's Hospital of Philadelphia, and University of California, San Francisco. And, you know, we use intraoperative ultrasound as a way of monitoring the fetus because there are really no good monitoring leads that last all the way through an operation. So ultrasound is used to supplement it and often is the only modality to measure heart rate to make sure the fetus's heart is not going to slow down so much that you're going to lose the battle and have early delivery. But I'm not aware of any data along those lines. Are you? Don? Well, if there is, it'll certainly show up because the three institutions involved in this randomized trial, those patients are followed really, really closely and reviewed by an external board and all of the rest. NIH has been extremely careful about safety, which is fine by us.
I just see an ad in one of the late-night cable TV shows. You'll know it's probably aside from spina bifida, I think that the indications and the use of prenatal invasive interventions has decreased.
Oh, I think probably. I think there's less amniocentesis being done because there are good serum studies, but there still is some need for it. I think it's less. We do it less, but you know, I'm not aware of every institution.
No.
In our three institutions, it's less. How much I couldn't really
I
say.
think the accrual of patients is hampered a little bit because of the widespread use of
We've had
folate vitamins.
Sure. Well, we have an awful lot of patients.
Yeah.
Awful lot of patients, and once you open a center like this, you're flooded with people. I mean, if we have 30 to 40 new patients a week.
With spina bifida.
No, with everything, I'd say with spina bifida, it's 4 or 5. All the rest are other abnormalities.
Coach?
One time, regional valves picked up bilateral hydro. You were putting intrauterine shifts.
Well, that is still being done, but it probably doesn't do a lot of good. Because what the main good it does is to relieve pressure in the abdomen and let the diaphragms descend enough so the lungs can develop. But in terms of renal damage, it's all over by then.
Yeah, just echoing that point, Dr. Neal. You know, I wish we could do more urologically speaking. You know, you have this information, but we're in the second trimester, the kidneys are already formed, so that's one of the reasons why the shunts fell out of play, is that it didn't change the renal demise. It was done already.
That happens very, very early. And you don't even know it's there at the time when that development is essentially complete. I wish it was, but
John? Is there any, for like a condition like pyloric stenosis that happens after the child is born? Is there any,
well, what people think is pyloric stenosis has been seen in rare instances on prenatal ultrasound and in the late stages of development, third trimester. But it's inconsequential, the number. It's basically a postnatal event.
But in terms of the patients that actually going to develop it?
No. There has not been any premonitory signal that this was going to occur. So it would appear to be an acquired disorder.
It's interesting, though. It's been associated with deficiency in endothelial nitric oxide synthase. That's the...
We're not down to the molecular level with prenatal imaging yet, though. But you know, that's not a wild speculation, because one of the horizons that's out there in radiology, particularly nuclear medicine, and has a direct relationship to surgery, is bioimaging. And of course that's important in endocrine surgery and a number of other things of that nature. And so in time, probably would be PET scanning, dynamic PET scanning with biological agents to allow imaging. We may be able to see some things like that. But the question then comes up, so what? If it doesn't have a practical use in the long run, it's a research endeavor that would just tell you about developmental biology and maybe or maybe not be useful. So it would mean very limited trials at first and maybe never implementing.
Good, nice discussion. Let's take a short break and then we'll go ahead with the rest of the research. Thank you very much, Dr.